I was listening to the bio and I'm thinking, okay, make sure you tell the office to change the bio, it's an old one. First, wow, what a wealth of information. I don't know about you, but I'm thinking, oh my God, we still have 2 presentations to go. And one's mine. So I've decided to cut the PowerPoint because I cannot coordinate anymore between taking notes and seeing it. But Carlos has it and it will all be sent to you. And I also felt I needed to change a lot of what I was saying based on presentation this morning. So we'll go from there. And honestly, where's Doreen? I think if we'd all agree on accountability and transparency for the billions of dollars that we pay towards healthcare, I could shut up right now and we'd be done because it is all about transparency and accountability, and we need to talk about it. I need to explain a little bit what the Canadian Federation of Nurses Union is. We're a young organization, just 30 years old. I wish it'd be me, but it's not. We're an umbrella organization of 9 nurses unions plus the Canadian Nursing Student Association. So we have over 180,000 members across Canada. Of course, we work towards improving patient care, working condition for healthcare providers, and we advocate for a national level for a publicly funded, publicly delivered healthcare system. So you know where I stand. I'm quite biased. For one of the speakers this morning, do not worry, nurses unions do not lynch people. And I see Dr. Duckett moved, except I really enjoyed the cartoons of Dr. Duckett when he announced there was no nursing shortage, not last August, but the August before. It was close to a lynching, I guarantee you that. But, you know, at 18 million hours of overtime a year in this country, that's close to 20,000 full-time positions just in overtime, and Alberta's on the top of it. Alberta's also on the top of payment, I'll agree with that, to 2 times the salary. They're also at the lowest of full-time position in the country, and they're at the highest of volunteer overtime in the country, to all our surprise, because why would you volunteer if somebody's paying you double your hourly rate to do the overtime? So when the announcement came, no more shortage, the lynching was close. But we're also, as Nurses Union, which is not our domain, because let's say in this province we do not represent nurse practitioners, and of course we do not represent physician assistant, but we lobby strongly against physician assistant. We have nurse practitioners in this country. They're growing every year, but they're being stopped. Why? Because of the monopoly of the medical sector. Why are physician assistants starting? Do not ask me. I do not understand. I've been on so many panels promoting nurse practitioner, promoting the expanded role of the clinical nurse in the community, in the acute care, in the long-term care, and all of a sudden, out of Winnipeg, where's Peter? Out of Winnipeg came a physician assistant, and now they're cropping up everywhere. Well, we'll have lots of to say about that. Of course, as unions, we work in collaboration with a number of groups, and I'll skip there. I come here from Ottawa via New Brunswick. If you haven't noticed yet, I have a strong French accent, which I'm very proud. I usually start in French everywhere I go, so I'll just say bonjour. But then I confuse everyone. They say, didn't you notice there's no translation? But I'm trying to cut it. My bio says I'm a nurse and I'm a proud nurse. But then on March 15, I read the newspaper. I get it on my BlackBerry because I'm addicted to my BlackBerry too. Addicted to annual meetings, addicted to my BlackBerry. And the headline was, from Alberta, doctors must be allowed to contribute to policy debate without fear. I thought, whoa, without fear, and those are the almighty doctors. I'm a nurse. I come here to give my opinion on the healthcare system. I hope I'm safe. You know, it is interesting that as healthcare professionals, we have to worry about giving our professional opinion on the system we work for, and it's, you know, it's more than a profession, it becomes a vocation. I always say, clip those wings and that halo as nurses. Don't get me wrong, you know, we're good and love a nurse poster and bumper sticker and everything, but you are a worker. You're not that angel of mercy, but you should not be fearful to speak your opinion. I and our organizations across Canada believe all healthcare professionals, not only nurses and doctors, it's always about us, I know, but we're kind of big in numbers, should be on healthcare boards, should be part of all the decision-making policy. Right now what the politicians are saying, no, 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 healthcare professional, please shut up. We want the public. Yeah, we want the public too, but the public has to be informed with the right information. It cannot just be charts and charts of numbers. It has to be what is caring, what is community health, what's the continuum of care, and what's really happening out there. So anyway, I won't go back home because I brought UNA to support me, but I'm not scared of speaking out my opinion, and hopefully doctors and nurses and other professionals won't be here too. So that's one issue. My presentation is to talk about the threats of the sustainability of Medicare, and I had to laugh because both the Stephen and Stephen team this morning said, you know, we're obsessed about the sustainability of Medicare. And my paranoid little mind thinks that's what the politicians want. They want us to be obsessed by the dollars and cents of healthcare, so we will never transform our healthcare system. You cannot imagine how many panels I sit on, and even when I got this one, I said the office, another one. You know, another discussion on the sustainability of healthcare when economists over the worldwide, because I'm not an economist, I'm a nurse and I'm paid to talk. Right now I'm talking very fast, I know. But you know, they say our healthcare system is sustainable. We need to change it. We need to change it to fit the need of the population. So I'll talk about this. I have to talk a bit about the privatization, but I'm glad Doreen was just before me and she was able to address a lot of this. I'll skim over it. And what factors will determine the future of healthcare and the way it's financed. And I have to do that in 20 minutes. Well, as I mentioned, I'm French. You can see, hopefully, I'm a woman. And I'm a union leader. 20 minutes is a challenge, I guarantee you. So, to begin, I first have to address, are we concerned? Are nurses concerned? Are unionized nurses concerned? Yes, we're concerned because of the debate going on, because of the discussion going on. Not the work we do every day, not why we do the work, but the debate. So the answer is there a reason for concern? It's yes and no. If we continue just talking about dollars and cents, yes, get worried. You young folks, get worried. Will you have a system if you ever get sick? You know, poor Peter, too bad he's gone, but when you leave a panel, you can get picked on. Peter, this medical, what did he call it? Medical fund we should all have. The government should give you $4,000 every year instead of giving it to the system, and you'd have this fund and you go buy a YMCA card. Okay, I'm healthy, knock on wood, but if I'm not healthy, if something happens, if I get hit by a car, oh, there'll be a special circumstance for that. There'll be a special circumstance for every individual in this country, because anything could happen to us, regardless of being hit by a car or a cancer developing that we don't know, not because we're not taking care of ourselves. One thing I agree with poor Peter is, yes, we have individual responsibility. Am I lynching him? Is that what I'm doing? But you know, one thing I believe we have individual responsibility. I'm not sure personally if we should tax, for example, as Dr. Duckett was saying in regards to fruit juices full of sugars, or should we penalize the people smoking in regards to tax, or if you're a smoker, you would have some kind of contribution to give more to the system. I'm not sure. Those debates have to be there. Just like prolonging life. Those debates have to be there. We're not having those debates. We're having dollars and cents. I was hoping the big sign was there. That's the debates we're having. We have to have the debates on our own individual responsibility of staying healthy. We know the federal government could do three things. One is a comprehensive plan on human resource. We need to know where and when and how, what are they going to be doing, nurses, doctors, and other healthcare professionals. We need a plan nationally. They've been talking about that since 2001. I've been in Ottawa since 2003, and every year I sit on a new commission, new committee to look at it. Still, we don't have it. Oh, we need a pharmacare program. The federal government needs to sit down and look on why is pharmaceutical going through the roof. Are they doing it? No. They even spend millions of dollars with their own little special committee looking at it of experts not doing anything. And of course, capital expense. You know, when Medicare started, the federal government had a big role with capital expense. They built all the hospitals around. Now our hospitals, maybe not in Alberta, because even if Doreen doesn't like to admit it, you are rich. Go in Montreal, which is not a small, poor province, the hospitals are falling apart. And that's just because I was there a few months ago. You know, and there's different examples everywhere. So there's a lot of capital interest that we need to be doing, and the federal government could be doing. So where does healthcare stand? We know it's a #1 priority with Canadians. A poll came out just before the federal budget, sponsored by nurses and doctors. 45% of Canadians said it's a #1 issue, plus 86% said we need to spend more money in long-term care, in pharmacare, in home care, in primary health care. They're saying we need to put attention there. What did the federal government do? The budget was last Tuesday, this Tuesday. Well, they're going to give $40,000 for a physician who wants to go in a remote and rural area as student loan. The last estimate I heard for a physician student debt was $120,000, $150,000. So you'll get $40,000. Nurse, you'll have a better deal. You'll get $20,000, and your student debts average around $40,000. So you're at least getting half. Wait till the medical society hears that. But you know, it's a peanut. It is a peanut into what we need to do as a reform in HHR. So they're not listening. And then they announce all proudly, oh, we're going to keep the 6% escalator clause to the province and territories. Duh. That is part of the health accord that was negotiated between the federal, provincial, territorial government. It's there till 2014. So some of my colleagues, you know, the righties or the lefties said, well, Linda, you know, Mr. Harper could have just canceled it. We have a big national debt. I said, he's not crazy yet. He's about to go in federal election. Do you think he was going to tell the province and the territories, the deal we negotiated with you, which is still on until 2004, the contract of 6%, I'm going to eliminate that, and vote for me, vote for me? Never in 1,000 years. But it was good. It's like the cutting of the ribbon, and that's what they do. Doreen, I always put little notes. Doreen called it bickering. I like that word, honestly. It's more polite than what I would have said. But, you know, it's pre-election, it's election mode, and nationally the sad thing, because of minority government, it's this flipping and flopping all the time. Sometimes I try to put French expression that they don't even go there. The silver tsunami. Bob Evans, which I respect very much, and I like quoting economists because I hardly can add myself. So, you know, I quote economists. But Bob Evans talked about it as the Great Glaciers, which 10.4% more Canadian will be seniors when the baby boomers reach retirement age. So one of the speakers all worried who's going to pay for us as baby boomers when we get there. Well, it'll take more than 25 years to reach that rank. And the cost to the healthcare system will be 1% per year. 1% for this big glacier that's coming down, us baby boomers that are growing older. One of the reasons is, even if you don't want to admit it, the baby boomers, the seniors of today, are healthier than my parents, than my grandparents, for different reasons. Our healthcare system is one. What we put in our mouth is a second. The way we see life is second. You know, they say that today's a 60-year-old is yesterday's 40-year-old, and it's true. You rarely see a 60-year-old today saying, oh, I'm ready to find a bed in a nursing home. Most of them are looking for their 3rd or 5th or 7th career. They want to do something else, more balance their life and their work, but they're not ready to go to the glue factory or the pasture. They're ready to do something else, and we have to take that. So where am I in my notes? Oh, the cost of aging, I mentioned 1%. The cost of inflation, 2.5% every year. The cost of drugs, 7.3% every year increase. Those increase. So the old folks, going to cost us 1% more. Inflation, 2.5%. Still not the cost of drugs, and we don't do anything about it. So are we in a crisis? No, we're just overusing that word. So, do we need to change our system? Do we need to look at the glacier or the seniors? Yes, we have to look at their needs differently. Because there's poor access to community-based. You heard Stephen Lewis. I was surprised he didn't talk about Canadian example. In his home province, they have a community health center that has dramatically changed the primary health system in that province. Great system. There's one in Ontario. They're growing everywhere. But for seniors right now, the lack of access is between 15 and 20% for older Canadians. And what happens? They go back to the hospital within 1 month of discharge. The impact of these efficiency not only costs patients their health, but also a great cost to the health system. And that's one reason one of the speaker questioned this morning was, how come you're only talking about acute? It's because our primary healthcare system, our community health system is so weak that where do they go? It's called a revolving door. They go back in the acute care sector, and we have to look at it. We need a national healthcare strategy, and why? It's because the professionals are working in different areas and should be working in different areas. We know that if we do it differently, for seniors, for example, there's research after research saying the more nurse practitioners, the more one-on-one, the more clinical the teamwork, the better they will be, and less they'll go in the acute care sector. So there's also a different term, you know, I call them nursing home, but that's not even probably in policy documents. They call them alternate levels of care. Big discussion in Alberta about those. But the problem for administrators, for bean counters, they call them bed blockers. Well, it's not their fault. They have no other place to go. A bed blocker is simply somebody, and most of the time they're seniors, that need help. They cannot go back to their previous place. They cannot go back home. There's no other place. Dr. Duckett mentioned the numbers of what we need to do in the next phase of our healthcare reform, and we have to be there. In Alberta last summer when I was here, the worst number I heard through Canada was a healthcare employer. Now, Duckett said, I hadn't met you before. A local employer, not the big cheese employer, said 45% of my bed occupancy are due to bed blockers. 45%, that's the highest number I've ever heard. And that's because of seniors don't have any other places to go. And then we all know about pharmaceuticals. Seniors cannot afford the prices of drugs out there. 9 out of 10 Canadians pay out of pocket for some or all their medicine. It's estimated that 3 million Canadians do not have enough or any coverage for drug treatments. I worked in the ER in New Brunswick. How many seniors came in that if you could sneak them a few of your sample pills, you did? Because they couldn't. They were dividing up their pills. They were not taking it. They were giving it to their spouse or their neighbor. They were managing their own drugs, of course, in the wrong way because they couldn't afford to do anything better. We need to do it. Is healthcare spending out of control? I think you've heard all the presentation except Peter, that it is not out of control. It has to be managed. It has to be transformed. And we have to show the cost differently. As you know, and most of you will know, our system is 70% public, 30% private. The 70% public is the hospitals, doctors, more or less, a little bit different everywhere, but that's what it is. And that hasn't changed in 35 years. It's always been between 4 and 5% of GDP. Never changed in 35 years. What has changed is the 30%, the private sector, and the biggest portion, again, is the drug. The only thing you remember from my presentation is we need a national drug program. Other than that, don't take any other notes. Some of you are too young to remember the 1990s, but Heather and I could show you the scar marks, the war marks. 1990s were awful in the public sector. And not only in Canada, everywhere, almost across the world. Big recession, what did they do? They looked at the public purse, we need to cut it. What is the biggest pie in the public purse? It's healthcare, we need to cut it. What is the biggest pie in the healthcare? It's nursing, we need to cut it. Just Ontario, 12,000 nurses gone like that. Nursing student, we used to graduate 12,000, we went down to 4,400 in a 10-year period. Now we're back to 9,000 because they realized they made mistakes. Same numbers for doctors, don't get me wrong, but I don't know those numbers as well by heart. So that's what happened in the 1990s, but also tax cuts. If we look in the last 15 years, the fiscal capacity of governments went down by $90 billion. About 6% of GDP they cut on tax. So, you know, we show the big, I don't have my slideshow, I didn't do it, but you know, you show Medicare or healthcare costs going up, and the provincial pie or the provincial portion going up, oh my God, it's scary. The provincial pie is shrinking. So yes, healthcare, education is another one. Now I know you're having a big debate on education in this province, just watch the news, but healthcare itself always had a same portion, but it's taking a bigger piece of the pie because the pie is smaller in regards to spending, and we have to realize that. Will increased privatization help control costs? Doreen talked about it also, but no. We just have to look at prescription drug. What did I say? One thing you remember, we need a national pharmacare program. Why? Because prescription drug has increased as a share of Medicare spending from 2% to 9% since 1975, sorry. So in 1975, we're only paying 2% towards drug, and now it's over 9%. The cost of drug rose from $4 billion in 85, just another date to confuse you even more, to $26 billion in 2007. So $4 billion in 1985 to $26 billion in 2007. And we wonder why we have the fastest growing drug prices in the OECD. Why does New Zealand, Australia are able to do it and we can't do it? A big report came from economists in the University of Montreal, and they proved to the federal government that if we would have a national pharmacare program, we could save up to $10.7 billion in this country. Federal government hasn't touched it yet. So, and it's not Linda Silas, it's not a branch of left-wingers that brought this paper to the federal government. It's health economists from a university based, you know, well-researched documents, yay thick, only numbers saying, if you do this, this is what you'd save. They haven't touched it. Skip a few pages, Linda. Oh, the pea trees. Pea trees are another, I could talk about that for hours, but Ontario, the Royal Ottawa Mental Health Centre, which I drive by almost every day, was supposed to cost $95 million and hold 284 beds. It was a pea tree. It opened with 188 beds, so close to 100 beds less, and at a cost at $146 million. So instead of costing $95 million, it cost $146 million. That was a pea tree. There's another example in Brandon. Was supposed to cost $350 million, offer 608 beds. The hospital opened with 480 beds, with a price tag almost double. That's a pea tree. And we don't know the contract, what's going to happen. Again, talking about accountability and transparency. Now, I'm going. Sweden. I have colleagues. I'm on several international committees. So the nurses union in Sweden belong to an international nurses union committee just looking at bargaining. Well, any Nordic country have a different life than us. One, go visit. You're not scared of being hit by a car. You're scared of being hit by a bicycle. They're healthy. They focus on health promotion. They focus on workplace, family balance. They have 5, 6, 7, 8 weeks vacation. Do you have that? You know, we start with 2 weeks, 3 weeks, depending on where we live. There's a different mentality, a different culture, so we cannot compare ourselves to Nordic country. We should. Social determinants are a big issue out there. They take care of their seniors. They take care of their homeless, if there's any homeless. We do not have that system in Canada. When we look at their collective agreement, yes, he's right, and I'm totally against it, but some nurses are trying to create their own agencies. Some do it in Canada too. They do it under the union umbrella, but they also negotiate private contract. So I'm Linda Silas. There's a basic collective agreement. I go to Stephen Duckett and say, Steve, I'm worth more than that. You either give me more or I'm going. And he has to do that with the 26,000 nurses in this province. Does he really want that? Peter doesn't care because he's a consultant. That's what's happening in Sweden. Every individual nurse can go and negotiate more than the basic collective agreement. The union is spending millions educating nurses on how to be great negotiators, and employers are spending millions on many more HR person just to deal with those individual nurses. So if you want it, let's go at it. Before I conclude, I have to congratulate the Alberta government on 2 things. When I was on my BlackBerry this morning, I noticed they appointed Anne McCullen for the Health Council. Very impressive. Won a high-profile appointment to look and to bring stakeholders, to bring the public into a discussion of healthcare in Alberta. We have similar programs in Saskatchewan, Quebec, and one for Canada, of course. Before I go on the Health Council, my second point to congratulate the Stelmach government is the last budget. Interesting. They not only looked at 1 year funding for healthcare, they looked at 4-year funding for healthcare. And for healthcare administrators and professionals, very important to know that forecast on where you're going. So when I go back to the healthcare councils, we have to wonder, why aren't we listening to them? The Health Council of Canada recommend HHR planning. That was their first year, 2002, 2003. They said we needed to transform the workplace. We needed to be the healthiest professionals, not the sickest. We have to look at the overtime. We have to look at the turnovers. Are we doing it still almost 10 years later? No. The Health Council of Canada recommended health promotion. They said just do it, stop talking about it. Are we doing? No. They talked about drugs. They talked about a national pharmacare program. They also talked about clinical guidelines. Are we doing it? No. So we talked about healthcare transformation system, and we focus all our energy on rebashing the old debate. Public or private, are we sustainable? It's a distraction, I mentioned it earlier. And it's to make sure that we don't really have real policy discussion. The Health Council of Canada talked about health promotion, pharmacare, and the council asked why in 2009 doctors wrote 80% more prescription than 10 years ago. 80% more. Why? It's also estimated that we have, or we get, 30 to 50% too many MRIs and CT scans. Why? 30 to 50 more. You have to answer your question why. The Health Council of Canada suggested clinical practice guideline, but is also asking for HHR planning. That was close to 10 years ago. We need to get down to business. In conclusion, Jeff is very happy. Even if I take my watch out, I don't even look at it. I know it's awful. But, you know, Roy Romano, and I take offense when somebody says Romano, then Kirby. Who was that? Oh, that was Peter. He's gone back to Manitoba. But, you know, Romano was the largest public consultation on healthcare we ever had in this country. He said said privatization is not going to work. We need to transform our healthcare system. We have to look at long-term care, home care, primary health care, pharmacare. Said it. Not only the cost, he said we had to transform it the way we wanted to do it. He said Medicare is as sustainable as we wanted to do. We all know that that report is a ghost right now in any government. So how do we sustain our healthcare service, healthcare without affecting services? We cannot do it. We have to change the way we do our business. You know, I looked at the country, yeah. You know, one thing I've learned being in Ottawa, because being from New Brunswick, small province, you just do it. You know, you talk, you pick up the phone, you can talk to the premier. You just have those connections. But I realized that we will not have one solution that will fit everyone. Last week I was in Nunavut. If you ever have a chance to go to the north, go. Unbelievable. But Nunavut has 243 nurses. 243. The size of Nunavut is 4 times the size of Ontario. 4 times. With population around 33,000. That's all. Their healthcare cost per population, per person, $8,000. Canadian, you heard from Doreen, it's about $4,000. Why? 1/5 of that is to transfer a patient down south. They call it Ottawa South, by the way. Okay, but each transfer is $25,000. So whatever we implement in Calgary, we can't implement in Moncton, New Brunswick, in PI, or in Iqaluit, Nunavut. We have to give the flexibility to the system. Stephen Lewis said, and I'll be quoting him a lot, the biggest question is productivity. It can't be doing more stuff. It can't be about what stuff we're doing, who's doing it, I would add, and where. Where are we doing that stuff? Is it only in the acute, or should it be in the community and the home? Last, the importance of the health accord. If you don't know what the health accord is, get informed. The health accord is due to finish in 2014. That's where the federal government went down from 16% paying the healthcare costs. They're back around 25%. Some argue, but they're back around that. They have a direct link. They need to start negotiating now with the province and territories before 2014. I was there when they were negotiating the last one. At 2 a.m., Prime Minister Paul Martin back then had a press conference announcing the accord. Imagine, they negotiated from one room to the other. We're more sophisticated than that when we're looking at a budget of $196 billion. We need to start right now, and it has to be talking about healthcare transformation, and we have to do it together. So I thank you for your time. Great day, I have to say, so many notes to take. But remember, we need you're going to fail, National Pharmacare Program. Merci beaucoup.